And we will go ahead and get started. Thank you for joining us for this Project ECHO, Maternal Child Health, Opiate Use Disorder, COVID-19 session during this unprecedented and challenging time. My name is Raquel Maison Jeffers, and I am a Senior Program Officer at the Nicholson Foundation in New Jersey. I will be facilitating this afternoon's discussion. The rapidly changing situation with COVID-19 necessitates a responsive, fluid, and interactive communication strategy. Project ECHO fosters partnerships between experts and frontline healthcare providers. It is based in education, begins with information, and extends to better outcomes. Today's session, which is the first in a series on this topic, was specifically devised for frontline providers in outpatient settings. For anyone who is familiar with the Rutgers Project ECHO telemedicine clinical offerings, due to shifting priorities, we have changed our previously scheduled topics in order to focus our resources to respond to COVID-19. Today's session will cover epidemiology and risk factors for pregnant and postpartum women, impact of new protocols on outpatient services for opiate use disorder and non-opiate use disorder, PPE, personal protective equipment for safety relating to labor and delivery. To set the stage, I want to share a quote from Dorothy Day as we navigate this triple epidemic of coronavirus, opioid use disorders, and maternal and infant mortality, all occurring within the context of persistent health inequalities. There is something about disaster and tragedy that unites us into falling together rather than falling apart. By way of introduction, I want to introduce our panelists today. First, Christine Scalise, who is a licensed professional counselor and licensed and certified alcohol and drug counselor, and the manager of the Women and Families Unit at the Division of Mental Health and Addiction Services, which is part of the Department of Human Services. We'll begin. Then we are joined by Dr. Damali Campbell, who is an obstetrician and gynecologist practicing in Newark at the Rutgers, New Jersey Medical School. Dr. Susan Neshin, who is the medical director at Jersey Shore Addiction Services Healthcare, or JSAS Healthcare. And Annette D'Angelo, who is a nurse at the University Hospital. We are sensitive to the urgency of your questions, and we're going to make an attempt to answer as many of them as possible on this call. I hope we can have a rich discussion and ensure your patient care questions are answered during our time together. Many of the questions submitted ahead of time were general questions about COVID-19 epidemiology, testing, and telehealth. Since this session is focused specifically on the intersection of COVID, pregnancy, and opiate use disorder, I would like to also direct you to two previously held ECHO sessions that covered the general epi and testing in detail and have been recorded. And the links can be found on the Rutgers ECHO COVID-19 webpage, and we'll also send them to you in a follow-up email. In addition, the Rutgers Project ECHO will be running New Jersey COVID-19 ECHO next week on telehealth and the time of COVID, and we will be sharing further details shortly about how you can sign in. To introduce you briefly to the technology today, if you've not already registered, we ask that you register using the link in the chat. The chat is also where you'll be able to ask questions during the session, which will be compiled and presented to speakers after their presentation. There will also be a significant amount of time devoted to questions and answers at the end of the session. This session is being recorded and will be distributed after the session, including any links and resources. Finally, as the timeliness of this content changes with each passing day, if you're viewing this recording at a later time, realize that this may not be the most current information at the time you are viewing it. Note at the bottom of the flyer on the COVID webpage, at the bottom of the flyer and on the COVID webpage, there are key resources links to the New Jersey Department of Health and CDC sites. So with no further ado, I am going to pass the baton to Chris Scalise, who will welcome everybody.
Hello, everybody. Good morning. So on behalf of the New Jersey Department of Human Services and Division of Mental Health and Addiction Services, along with the Nicholson Foundation, Rutgers, and Robert Wood Johnson, and our esteemed panelists, we are pleased that you are able to take the time to participate in this ECHO. We know that COVID-19 has a significant impact on our state, our consumers, your patients, clients, your loved ones, yourselves, and families. And the fact that you're able to participate and share and hear what is happening across the state is very helpful to us. And as Raquel had previously said, this webinar will focus on maternal child health and opioid use disorder. The series will focus on the impact the pandemic is having on our maternal child health, including our inpatient and outpatient services, how access to support services and community resources can be helpful. And we're also hoping to create an opportunity to provide you all with some useful information to guide you in the continuation of services to pregnant and postpartum mothers, specifically to those who are in recovery. Hopefully, we'll be able to address the questions you submitted around COVID-19 and its effects on maternal child health. So as Raquel had said, to start our first session today, we will address the epidemiology and risk factors on pregnant and postpartum women. And we hope that with this ECHO, our presenters will discuss further areas of concerns in their presentations. And afterwards, you'll have the opportunity to pose questions for them in the Q&A. With that, I'm turning it back to Raquel, and thank you again for joining us today.
Dr. Campbell, you can take it away. You're next. You should be unmuted.
Okay, great. So again, I'll add to everyone's welcome. Thank you for joining us this morning. And we have a lot of material and a lot of questions, so I want to jump right in by talking about the epidemiology. And I think most of us know by now that mainly the spread of the virus that causes COVID-19 is through respiratory droplets, but also through the touch of objects where respiratory droplets may have been left. And so I just wanted to point out that epidemiology is a field of medicine where we really study the patterns and frequency of disease and the cause and effects of disease and health outcomes. And so when we think about epidemiology, we really think about the patient as the community and not as an individual. But epidemiology forms the basis for evidence-based medicine and the development of strategies for improvement of public health. Next. So the epidemiology of COVID-19 and pregnancy, I want to caution us, we are getting so much information on a day-to-day basis. But really, this evidence is really based on available data, which is anecdotal, and on observations from China, from Italy, and now from the US. But it's not a study. So I just want to emphasize that there are observations and they are valuable, but we just have to be careful in how we extrapolate the information that we're receiving and generalize that information. Current available data does not indicate that pregnant women are at increased risk, particularly for COVID-19, but we know that pregnant women are considered relatively immunosuppressed, and in general, not only from COVID-19, but from our experience with other respiratory infections like influenza and other infections that cause acute respiratory distress, that pregnant women seem to suffer with a greater risk of severe morbidity and mortality. So having said that, pregnant women should be considered an at-risk population for COVID-19. Currently, there is no evidence for mother-to-child transmission during pregnancy, but of course, after birth, newborns are susceptible to transmission, just like everyone else, from person to person. And to date, the virus has not been detected in amniotic fluid or in breast milk. Next. In times of crisis, our vulnerable populations are affected in a greater fashion, both short-term and long-term. And so I want to focus our discussion a little bit on our opioid use disorder patients and our pregnant patients. And so our opioid use disorder patients are very vulnerable, as well as our pregnant patients are very vulnerable. So when we have a pregnant patient who also has opioid use disorder, we would say they have two risk factors. In addition, we do need to recognize that there are other factors that may exacerbate poor outcomes, like food insecurity, homelessness, domestic violence, and intimate partner violence. And due to the crisis, our patients may be experiencing a loss of income, a loss of insurance, additional child care responsibilities, and they may be looking to self-treat anxiety or depression, which we know is prevalent in our opioid use disorder patients. So in addition, of course, our opioid use disorder patients can have chronic medical conditions. They can have asthma, they can have diabetes, hepatitis, and they certainly have a high incidence of smoking or vaping. And so in addition, our social determinants of health that we've discussed, food insecurity, can affect the immune system, and these other social determinants of health, like homelessness, and jobs that they have to go to work to, could affect their ability to have the proper social distancing or perform good hand hygiene. And so I know that there has been there's lots of work, ongoing work being done in our opioid treatment centers, both inpatient and outpatient. And we have an expert who's going to go into some more detail about that in the next few minutes. Next slide, please. So I just want to talk about, in the real world, there's no specific protocol for patients with opioid use disorder versus those without. Our substance use disorder patients are a small subset of our obstetrical patients, and they have additional risk factors. So many offices have policies that have been set up to instruct patients to call first, and that's not always practical for our active using patients or for low resource patients. It's important because it allows for us to screen for symptoms ahead of time and to discuss visitation policies, particularly to the hospitals that have been adjusted during this time. All of our clinics and contact points are changing to have the first person who contacts the patient should ask about symptoms. And so that might be out of the traditional role of the first person. It may be a receptionist, it may be a medical assistant that are asking about the symptoms. But we have to realize if our patients are homeless and they may be in the elements, they may not have an initial temperature, they may not register a fever. And if they do have a fever, we can't forget that our opioid use disorder patients are at risk for other etiologies for fever, like endocarditis and abscesses. Testing sites and testing practices are varied. And at this point, because we don't have the availability for universal testing, there are symptoms that are required before many people have been tested. On labor and delivery, We want to have the personal protective equipment available. And we want to consider designated staff to deal with patients that may be persons under investigation or have been proven to have COVID. We know that there is a high exposure to respiratory droplets, breathing, panting, screaming on labor and delivery. And so we do want our staff to be protected. And while travel history was initially very important, it's really no longer a necessary component of the history in terms of thinking about the virus that causes COVID-19. Next slide. So we can all go on the New Jersey website. This was as of Friday. And sadly to say, today's numbers are increased. We have 61,850 positive people with 2,350 deaths. And so this just gives us a feel for the counties that are heavily affected, but you can see that there are patients being treated for this disease all over our state. Next slide. I think as an obstetrician and also a physician that treats patients with addiction, I want us to not forget that we need to be laser focused on maintaining good maternal practices, continue to screen and treat substance use disorder because it is an essential service that we're continuing to offer. We're able to incorporate telehealth in all aspects of care for those who have the technology, but we do need to remember that some of our patients may not have the technology, particularly in terms of attending meetings. But there are lots of resources in terms of online or telephone meetings that they can attend. I think that it's important for us to continue to ask patients about how they're managing stress during this crisis. In all of our patients, that's an issue, but particularly in our patients that have substance use disorder, because we know so many of them may resort to tobacco use to manage stress, and that can impair their recovery. And I think that we want to think about some anticipatory guidance for patients because they may be thinking if it's safe to deliver in the hospital and am I a candidate for home birth. Next. So how do we provide care and be safe? Again, the telephone check-ins and telemedicines, recognizing that patients are afraid and trying to give them some tools to deal with fear and anxiety. We may see an increasing number of extramural deliveries or intentional home births, but as a fellow of the American College of Obstetrics and Gynecology, we still feel that the hospital is the safest place to give birth, and particularly for our opioid use disorder women. I'm talking to them about the fact that they want to deliver in the hospital because we don't know the condition of the baby when they're first born, and we want to be able to give them immediate medical attention if it's needed. I think all of us who work in maternal child health will rely on our basic training. And just remember not to get lax. We are in the thick and the proximity of blood and bodily fluids and secretions. So we should be using PPE. Next slide. And I want to just emphasize that taking off PPE is just as important as putting it on. And again, we have an expert who's going to join us to give us some tips about our PPE donning and doffing. Next slide. So I want to kind of end with a little acronym, which I shamelessly stole from the Weissman Institute. Face COVID, a model for dealing with current stressors. Focus on what is in your control, acknowledge your thoughts and feelings, come back to your body, engage in what you're doing. We all are in this field because we have a commitment to action. Open up, identify our values, and identify resources, but don't forget to disinfect and distance. So from there, I'll turn it back over to Raquel for our next presenters.
Thank you so much, Dr. Campbell. Okay, so some questions are coming in, which we're going to hold for the end. I just wanted you to know that I am acknowledging the questions that are already in the Q&A, and if you have questions, please type it into the Q&A function. And now it is my pleasure to introduce Dr. Susan Neshin.
Good morning, everyone. I am Medical Director of JSAS Healthcare, which is an outpatient opioid treatment program in Neptune, New Jersey. We have 750 patients in our treatment program. We provide mostly methadone, but we also do buprenorphine treatment and opioid antagonist treatment with naltrexone and Vivitrol. I apologize, I don't have a PowerPoint, but I really wanted to kind of take all of you through what we have had to do over time since the onset of the COVID pandemic in terms of our day-to-day functioning, how we treat our patients, what modifications we've had to do, and there have been quite a few in order to adequately continue to treat our patients. So first step is we had to deal with crowding. I mean, we needed to do social distancing. However, we have 750 patients and many of them come 6 days a week. The 6 days is open, early in treatment or not stable in treatment and haven't yet earned methadone take-homes. So we were considering social distancing and started doing that by having people wait in their cars, or we have a lot of patients who come in Medicaid vans, which are very unsafe because people are crowding in one van. And we were trying to just have 10 people at a time kind of space themselves 6 feet apart in front of the door. The others we would have waiting, and then we would have people go into the clinic one at a time. That was step number one, which turned out to be a disaster because nobody was willing to stand 6 feet apart, and the parking lot was filled with kids running around and people in and out of their cars, and it was kind of pandemonium. So we all had to start scratching our heads and consider our other options. We are a suburban clinic, so we are fortunate in that many of our patients drive to the clinic. We have a large parking lot. So we decided to do a drive-up service. And in conjunction with this, we had gotten approval from both federal, the SAMHSA, and the state methadone treatment authority to allow patients many more methadone take-home bottles than they normally earn in treatment. And that was a source of both relief and fear on our part because patients who are early in treatment, who may have relapsed and are not doing well in treatment, giving them many methadone take-home bottles was kind of a frightening prospect, concerns about not taking them properly, diversion, all of those things. So we had to weigh the dangers of that versus the safety of both our staff and our patients. So we're in conjunction with giving out many more take-homes up to the least amount of days a new patient would come in is every other day, Monday, Wednesday, Friday. And patients who've earned a few take-homes are getting either a week at a time, 2 weeks at a time, and up to 4 weeks at a time. So with that, we were able to not see as many patients in any one day. Our nurses are working kind of round the clock, pre-pouring methadone so that we can bag them. We've given all of our patients, we purchased and are giving all of our patients a lock box that they can carry home with them to keep their methadone as safe as possible. And it has worked out incredibly well. We don't have lines. The patients come up to the back door of the clinic, and one of our nurses is out there bringing their take-homes to them. And it's been a pretty smooth process. I will say, though, that many clinics in New Jersey are not a suburban clinic like we are, and they can't do that. So they still have patients. They're giving more take-homes, but they still have patients who are coming through the facility, potentially infecting each other and infecting staff. So there are many more safety concerns with some of the urban clinics. I mentioned about the extra take-homes. That really is, we have thus far not run into any real problems. The only thing that was reported is my director of nursing said that a number of our new intakes who are coming in have been buying methadone on the street, and it's blue methadone, which is the color of our methadone that we put the dye in, and they're 30 milligram amounts, which tells us that the new patients who are on the lower doses, the 30 milligrams that they get when they first come into treatment, are the ones who are selling to other people. And my feeling about diversion is that typically methadone gets in the hands of another addict, and it ends up saving them a day of using heroin multiple times a day. So mostly we don't run into problems with diversion unless it gets into the hands of somebody who has minimal to no tolerance, and then it can be potentially fatal. I will tell you, though, that I was recently on a call with medical directors in New Jersey and with the state authority, and thus far, there has not been an increase in opioid overdoses reported since we've started giving the extra take-homes that all of the clinics have been giving. So that is a little bit of relief. And we're hoping it will stay that way. Another thing that I've done, that whether it's an outpatient opioid treatment program or outpatient substance abuse treatment programs in general, we've all gone to telehealth. So our counselors are either in the clinic or working from home doing telecounseling with all of our patients. It's been difficult to make sure that all of our patients can be reached, as many of them change telephone numbers, their phones are out of service, but we're working very hard to stay in touch with as many of our patients as possible. In addition, we have on our staff, myself, who does psychiatric treatment, and we have 2 therapists. So we're better positioned to address some of the mental health needs or therapists reaching out to their patients as well. What we've done, we have to take new patients into treatment. That's a mandate because we receive federal funding, but it's our mandate as a provider of substance abuse treatment. We need to, people are suffering out there and they choose to come into treatment. We need to welcome them into treatment. So they are the only patients who actually walk through the doors of the clinic. And most of the intake process is done by telephone. Our intake counselor, who does a very thorough intake evaluation, does that by phone. The nursing assessment, for the most part, is done by phone. The only time the person comes into the clinic is to leave a urine drug test so that we can make sure there are opiates in their system. And the physician goes over the consent for treatment and does vital signs. Other than that, they are not in the clinic. So that has worked out very well. We always give priority to pregnant women and people who have recently had an overdose. They come to the top of the the line. And while we're limiting our intakes at this point to Monday through Wednesday, if a pregnant woman walked in the door on Thursday, she would be treated without question. There were some concerns, and there's a lot of talk among opioid treatment programs about whether or not we need to do a face-to-face physical exam. And many are saying that it's not really necessary as long as basic vital signs are done to really do that, since most programs don't have PPE adequate to perform a really thorough physical exam. So we have done the minimum. The physician talks to the person at length by phone before getting the vital signs. But we've decided that for now, limiting the full physical exam is what has been necessary. The other concern we have is drug testing. Till now, since we started this process about 3 weeks ago of the drive-through and the extra take-homes, we have not done testing. We know that this can't go on for too much longer, because just as somebody who's in treatment for hypertension needs to have their blood pressure checked, we need to do drug testing on our patients. And there have been lots of recommendations or suggestions for how to do it. There are even some where a person gets a testing kit sent to them, and they do it via Zoom conference. But I don't think that for most of our patients that is going to work. So we are struggling and have not quite yet figured out how we're going to do it, but we're working on possibly setting up a big tent out in our parking lot to be able to do the drug testing outside. We do a lot of oral fluid testing. The other concern, though, is that because this is oral fluid, that may not be the best testing to do under the circumstances of COVID. So that's a work in progress at this point. And I will just tell you that every single clinic has a different protocols. They're doing things differently based on their demographics, their geographic location. We feel very fortunate that we've been able to do things the way we are. Just to get to pregnant women in particular, as I said, they are a priority for us. We are one of the few clinics in New Jersey that have a specialized perinatal program within our opioid treatment program. So our pregnant women have a special counselor. We have a relationship with Jersey Shore University Medical Center. One of their perinatal nurses works at our clinic 2 days a week, sees the patients in the clinic. We run all kinds of support groups. So they get a lot of specialized care. Unfortunately, the support groups are no longer available. However, individual counseling through telemedicine still is. And our perinatal nurse still does come by, and she sees all of our patients in the OB clinic at our local hospital. So from that standpoint, everything has gone pretty smoothly. I don't think our patients have any more concerns about delivery than pregnant women at this time. There are lots of questions, more, I think, some fears, but actually more disappointment about not being able to share this experience with family members after the baby is born. I mean, they can have one partner in with them, but you have a baby, you want to be able to have parents, other family members, friends share in your joy. And it's really, that joy is mitigated because social distancing and isolation, and just that's not a possibility. So that's been expressed a lot. In our local hospital, they are just starting, as of this week, to do rapid testing on all of the pregnant patients. Up to now, they have not done that. They will not, at this point, be doing the partners who are coming in the delivery, but just the pregnant women. and everyone in the room must wear a mask, including women in. And I know that varies from hospital to hospital because my daughter is pregnant and due any day now, and she will be allowed to labor without a mask. So every hospital, just as Dr. Campbell mentioned, have different policies and procedures for that. I think that there are now 3 Hackensack Meridian hospitals that have the rapid testing, and they will be doing that. So I'm going to end it at this point, and hopefully there will be a lot more questions. But just know that there's a lot of discussion at all different levels about how OTPs, opioid treatment programs, need to function with COVID, and even among different organizations, there are different recommendations. The American Association for the Treatment of Opioid Dependence has a lot of concerns about so many take-homes being given out, and so there's a lot of back and forth among agencies, and we're constantly on conference calls and trying to change and update our protocols to conform with all the standards we need to conform to. Opioid treatment programs, as most of you know, we are separate. We are an essential medical service, so that we have to operate, but we are separate to some extent unequal in terms of being a part of the medical system. So I'll stop there, and hopefully there will be a lot of interesting questions. Thank you.
Thank you, Dr. Neshin. I'm just checking to see, is that Annette? Hi, great. So our next speaker, again, there have been questions coming in. We are tracking them, and we'll be happy to get to them after the presentations. Annette D'Angelo, who is a nurse at University Hospital, I think is going to be addressing issues related to PPE.
Okay, and thank you. Thank you so much for having me. I just want to go over briefly what we're doing here at our hospital. Some of the methods may be different in other institutions, but this is what we're doing here at University Hospital. Each day, everyone is waiting online very patiently to get their allotment of PPE. And sometimes the line is very long, but it's important that we always stop there in the morning to pick up our N95s and our face shields. We also get a regular surgical mask, because here to preserve the N95 mask, you'd be wearing this with a regular mask over it, so that if the outer mask gets dirty, this is replaced. And these are more readily available, obviously, than the N95s, which are so precious. So we are keeping these. At the end of the shift, the staff is asking that they go back into the paper bags, and we have a special receptacle on the units, and there's been some discussion of how they will be reprocessed, though we don't have a policy yet on how that will occur. So right now you're depositing it, but each day you will get a new one. The face shield, which is really going to cover your whole entire, and you can see will cover your face, this you keep until it is too cloudy to wear, or it rips or tears. With these, we will be cleaning after each use, after each patient that we use it on. We do have a process for reusing the face shields. So the expectation is when you're going to the unit, you will have your face shield and your masks with you. When you get outside the patient's room, you will put on your N95 if the patient is on airborne precaution. If they're not on airborne precaution, a regular mask will be fine. Like I said, again, this is our hospital policy. You know, other hospitals may have other ways of doing their precautions, but this is the way we're set up here right now at University. Of course, it may change. But right now, airborne is where we wear our N95, then we put a regular mask over it, and then you're gonna put on your face shield. Once all that is on, it's really important that it's comfortable, that it fits well. If you have not been fit tested for your N95 mask, we have fit testers available all day long. You can always go and get fit tested. Or your mask that you were using last week is no longer available. You'll have to be fit tested on a new mask. That's really important that everybody make sure your fit testing is done well. that fits properly. No sense in having an N95 on if there's lots of air gaps and things are getting through. It's not going to protect you. So that's really important. So wherever you pick up your mask and stuff on the D level, that's also the same level where they're doing the fit testing. So be sure and tell them that, this is a new mask. I need to be fit tested. Outside the room, you're going to have your mask, your gloves, and your eyewear on. Of course, always remember hand hygiene. There's a myriad of hand sanitizers across each and every floor. You should have no problem finding one. So before you put anything on, always do hand hygiene, to make sure you get all the crevices inside, double fingers. I think everybody's seen those videos over and over. But it is so important. Put on your mask, put on your eye shield. That's going to stay with you. You only need to change that when you go from patient's room to room to room. If you're going to be staying in the room and you're just coming out to get something, you do not have to keep taking it on and off. Just be aware of that. So you might want to, just be careful when you're touching it. You don't want to dirty it because that's going to be yours. You're taking it with you for the whole entire time. This could go, if you hope it lasts a few days, so that we don't run out. Outside the room, you have gowns. And because these are the blue gowns, you also see yellow gowns. Yellow gowns have 2 ties at the neck. The blue one does not. It has a hole. So what we're recommending is that at the perforation, tear it. Why? Because you really don't want to be putting this back and over your eye shield. We're trying to keep that clean. So we will tear it and then tie it behind the neck and then tie it behind the back as well. It'll be a little bit hard for me to get it that, but then you put your arms through the sleeves and through the hole like that. And then you're going to put on gloves. When we put on gloves, the important thing to remember is that once the gloves are on, to sanitize the gloves. And the theory behind that is because your box of gloves, each and every person keeps sticking their hands in and out of those gloves. So in order to minimize contamination of the glove before we go see our patient, we will sanitize the gloves as well. So now all of us are ready to go, and we're inside the room. We're taking care of our patient. Like I said, airborne will be the N95 regular mask eye shield. So now we're getting ready to leave the room. So when we're ready to leave the room, before we leave the room, the important thing is you're just going to take off your gown and your gloves. So we rip it and then we pull it down, always trying to protect our hands and making sure that we slide it from the inside. Pull it off. And I recommend that you not stand there and roll it up. The least you touch this, the better. So as long as you have it enough, we can get it in the garbage, you're good. Hand sanitize again. And then we're going to step out of the room. We step out of the room, we're going to hand sanitize, put on clean gloves, and you can then take off this eye shield. We can use the Sani wipes to wipe it down. We have Sani wipes that are 1 minute and 2 minutes, so you got to be careful. We did actually get some 1 minute. So it would be important to make sure that you know how long it has to dry. And then you can just take it and use it for your next patient. And that's where you can use your eye shield. So that's why we try to minimize how much we touch our face or in the room. Anytime you're going to take this off, clean it, you take off your gloves, do hand hygiene again. So every step of your PPE will require hand hygiene. And if you remember to do that, it's really the safest for you with your PPE. If this becomes ripped or damaged during the course of your day, just let people know downstairs. You don't have to show it and drag it down there. But just let them know that you need a replacement. But we really are trying to preserve, because you know how precious our PPE is for us. And this will go at the end of the day. For the staff, we say the end of the shift. We'll go in the paper bag for reprocessing at a later time. We haven't made no decisions yet, and get a fresh one for the beginning of your next shift. Thanks.
Thank you so much, Annette. That was just a fantastically helpful and visual presentation. I've been on other calls that haven't always done that so visually, so that was terrific. Thank you.
You're welcome.
Okay, so I'm going to attempt to kind of weed through some of the questions and field them out. There are a couple of questions about the mom and the newborn being able to remain in the same room together, to breastfeed, questions about concerns about not just the health of the baby, but all of the amazingly important attachment issues that happen immediately postpartum. So I'm wondering if you might be able to share what you're seeing and thinking about, and how hospitals may or may not be coming up with policies with respect to keeping moms and babies together and or separating them.
So, um, so this is a hugely important topic. And I think, one of the things that I would urge everybody to look at, and of course, these are ever-changing resources, but ACOG, and they have really done a wonderful job between ACOG and the Society of Maternal Fetal Medicine, along with the CDC, to have one resource in regards to a lot of these questions that are coming up. I know at our institution, if we do have a mom who is COVID positive, they are separating the babies from the mother. And that's really just for observation to make sure that the pediatricians are able to observe because there's so much that we don't know about this virus and how it's going to affect babies. We still are definitely encouraging mothers to breastfeed. And as I stated before, there has been, to date, the virus has not been found in breast milk. But of course, this is based on very limited information. So we do really still encourage moms to breastfeed. So how does that happen if we're separating moms and babies? I know somebody's asking that question. And so, it's hard, it's really tough. But what we're doing is we are encouraging breastfeeding. We're encouraging moms to wash their hands and to wear face masks. And if they're going to pump, if it's a situation where mom needs to pump because the baby is separated for additional reasons, maybe for NAS, then definitely we want to go over the procedure of washing hands and cleaning the pump very well and all the parts of the pump. And we actually have handouts in regards to that and instructions for mom in regards to that.
Thank you, Dr. Campbell. There also have been some questions, maybe it's kind of the intersection of Dr. Neshin and Dr. Campbell about if a support person, particularly a dad, is also a methadone patient, because currently the instructions are that once a support person enters the labor and delivery floor, they are not allowed to leave the labor and delivery floor. Are there measures in place to provide methadone medications to dads or other support people while they're in the hospital providing support through labor and delivery?
I guess I could speak to that a little bit, only in that because of what I mentioned earlier, that most of our patients are getting multiple take-homes. They should have and be able to bring methadone with them to take. If in fact they need extra, they can contact us and we would be able to prepare extra take-homes. I know it's kind of, if they're rushing off to the delivery room and they're supposed to be at the clinic that day because, they need to pick up their medication, that could be an issue. However, I know that our hospital, if a patient for whatever reason couldn't make it to the clinic and they went to the emergency room, they would be able to get a dose of methadone. So I believe at our hospital, because we have such a working relationship with them, that if a patient didn't have their methadone, they could call us, the staff or the pharmacy from the hospital could call us and confirm dose and be able to get a dose to that support person.
So I can say that we haven't had that situation come up yet, but I think it's a great question, and it's going to lead me to go back to our nurse and head people to talk about that, because that could certainly happen. For now, I think the workaround that I would think about is just having that support person get everything they need, contacting their clinic and getting everything they need, knowing that once they come on the unit, that they're not going to be allowed off, and once they leave the unit, they're not going to be allowed back on.
There was also a follow-up question, Dr. Campbell, for a mom who is COVID negative. Even if her baby's in the NICU, are they still allowed to have skin-to-skin contact with infants?
Absolutely. So, I mean, in terms of, and I saw a question in regards to NAS. I mean, we certainly want to promote skin-to-skin contact for babies who are at risk for neonatal abstinence syndrome. So we try to provide that. So when babies are in the NICU, I know in our facility, we try as best as we can to facilitate skin to skin, or what people call kangaroo care, for those babies, because it is very helpful in terms of reducing their risk of NAS.
Thank you. We also got a number of questions about kind of the sequela of infection in opiate use disorder patients. So patients who are we seeing anything different? Of course, it's way too early to say anything definitive from an evidence perspective, but are we seeing anything different in the sequela of the infection of COVID-19 with patients with opiate use disorders?
I think it's way too early for us to tell, but there are lots of populations that we are keeping eyes on, patients who are HIV positive. And, you know, we're worried because of the inundation in many hospitals in the North Jersey area with COVID patients. One of the things that we know is happening is that other patients who may normally come to the emergency room with heart attacks or strokes may not be making it to the hospital in time. And so then the question comes to beg if there would be more overdose. But as Dr. Neshin said, we haven't seen that, fortunately, yet. And so we hope not to see that, but that's something we will be keeping an eye on.
Lots of questions about when it's safe for people to return to contact after a course of the disease, right? So questions about case managers, how they can meet patients' needs, and when it's safe again to have interaction with a patient who has already had COVID.
Direct people, there are actually guidelines for this on the CDC website, and it all hinges on whether the person just tested positive but was otherwise asymptomatic. The vast majority of people who have the virus that causes COVID-19 have very mild illness, and then another 10 to 15%. And we've seen this again. We don't have all of the United States data because we haven't completely been through the pandemic, but from what we look at from some of the other countries, about 10 to 15% have what we call moderate illness, and then about 5% have severe illness. So a lot of the recommendations hinges on whether the patient had mild illness or whether they had severe respiratory illness. And then the days to reduce contact are based on that, their symptoms, as well as when their symptoms first appeared and when their tests were positive.
Great, thank you. I think this, maybe Dr. Neshin, you can answer. There's a question about prescribing mental health medications like ADHD medications for longer than 3 months, and whether there have been some accommodations offered from a regulatory basis.
From what I understand, and there's on the DEA website, deadiversion.gov, there are a lot of answers to a lot of these questions. I know that we are allowed to do, as long as it's video telemedicine, not just phone. You could start somebody on an ADHD medication, which might be a Schedule 2, even if it's not a face-to-face, but as long as it is a video health session, it would have to include video so you could see the person. You can, as we've been able to do all along, give the 3 months of medication by writing 3 different prescriptions and just putting do not fill before on each of the other 2. After the 3 months, so far, there has been no change from what I can see in requiring that after that you need to have a new prescription. It could be by e-prescribing, it could be a physical prescription, it could be mailed to the pharmacy. It could, I've done mailing actually to patients, if given enough time before they run out of their medication to be able to prescribe. And certainly for anything greater than Schedule 2, we know that we can call those in. So there has been some accommodation, not much, but I believe it doesn't have to be an initial face-to-face.
Right, thank you. So on that theme, there have been a lot of questions about telemedicine, billing codes. First, I wanted to say that we are working on an upcoming ECHO session, specifically on all of the regulatory allowances that are coming down the pike, which is changing very rapidly to support telehealth and billing codes, and we should have that ready for everybody to participate in next week. But I just was wondering if perhaps Dr. Neshin or Dr. Campbell has any advice on kind of immediate practical thoughts about transitioning to telehealth in terms of HIPAA issues and billing issues.
I can't speak to it too much specifically because in an outpatient, in an OTP, an opioid treatment program, we don't have to do the same kinds of billing codes. For example, our Medicaid reimbursement is a bundled rate. So we're not often using individual billing codes. Our transition to telemedicine happened very rapidly and was strictly by phone. It is only now that we are starting to look into not necessarily Zoom, because I understand Zoom is not as secure, but there are a number of other ones, DoxyMe being one that we're going to be starting to use, which at least is HIPAA compliant. It's not going to meet some of the 42 CFR, which are specific to substance abuse, 42 CFR Part 2 confidentiality regs, but I think it is certainly more secure probably than Zoom. And we're going to be starting to use that, but I would say, at least in my population, it's not going to be very popular. Most of our patients, or many of them, don't have access to all the equipment that you need. They may have a smartphone that works sometimes, doesn't work sometimes, it's turned on, it's turned off. And they may be living in an environment, whether it's, a homeless shelter, or they're living, with lots of family members, that they're not going to be able to do that video conferencing. That's kind of the gold standard of what we should be doing. And for the most part, the phone sessions have worked very well. Once we can contact a patient, they feel very comfortable, and our counselors and therapists and myself feel very comfortable doing it that way.
Dr. Campbell, did you want to add anything?
Sure. I would direct people, if they work with the health system, to look at the resources for their health system. I know for our health system, we were given certain resources to be able to scripts in order to introduce the idea to patients and get their permission. There are certain regulatory issues in regards to where the physician is located and where the patient is located. So you want to be aware of those. And if you don't work for a health system, then the other place I would direct you to is the professional societies. So I know ACOG, which is the professional society that I belong to, as well as ASAM, both have resources on their website to help guide us through how to deal with telemedicine and telehealth. And I echo the other points that Dr. Neshin said about the patients that might have low resources. That's going to be a barrier.
I do know that DCA has just loosened the regulations, so it doesn't have to be a video visit. You can, a phone visit is sufficient and billable event as well. So I just wanted to emphasize that. And then I believe we are nearing the conclusion of our call, so I'm just going to wrap it up and thank our presenters so much for their time. As we approach the end of today's ECHO, we want to thank you, the participants, for attending and participating. The session has been recorded, and we will be distributing the call, and it will also be made available on our New Jersey Project ECHO COVID webpage. We'd also like your feedback regarding your interest in participating in subsequent sessions on the subject. Please take a few moments and complete our post-session survey so that we can gauge your interest and plan for upcoming sessions. Thank you again, and please, the dates and times of the next COVID ECHO session will be announced shortly. So please keep checking your email, and thank you all and stay well.